Welcome to the Behind the Shield podcast. As always, my name's James Gearing, and this week it is my absolute honor to welcome on the show Doctor of Radiology and the Medical Director of Primary Care Radiology at Prenuvo, Dr. Yosef Chodakiewitz. Now, in this conversation, we discuss a host of topics, from his journey into the world of medicine, the scope of practice within radiology, innovations in modern-day MRI, medical applications of ultrasound, the safety and efficacy of full-body preventative MRI scans, the application for the first responder professions, spine health, cancer detection, warning signs of potential aneurysms, and so much more. Now, as a side note, Prenuvo is offering you, the audience of the Behind the Shield podcast, 20% off any scan through their Warrior program. And I will put the link to that on the show notes. Now, before we get to this incredibly powerful and important conversation, as I say every week, please just take a moment. Go to whichever app you listen to this on, subscribe to the show, leave feedback, and leave a rating. Every single 5-star rating truly does elevate this podcast, therefore making it easier for others to find. And this is a free library of almost 1,200 episodes now. So all I ask in return is that you help share these incredible men and women's stories so I can get them to every single person on planet Earth who needs to hear them. So with that being said, I introduce to you Dr. Yosef Chodakiewitz. Enjoy. Well, Dr. Sefi, I want to start by saying thank you so much for taking the time and coming on the Behind the Shield podcast today.
Thanks, James. Thanks for having me. Glad to be here.
So where on planet Earth are we finding you this afternoon?
Well, I'm actually in California, in Palo Alto, which, I can't complain about because I know most of the country now is under some severe weather. So I hope everyone is keeping as warm as possible and staying safe.
Are you getting any edge of the band? We're going to get some cold weather starting tomorrow. For Florida, it's going to be quite cold. But what about California?
This weekend was beautiful actually. In my area in Palo Alto, sunny skies. It wasn't particularly warm, but it wasn't particularly cold either. Just was out and about with family and kids, parks and birthday parties and things like that.
Absolutely. All right. Well, then I would love to start at the very beginning of your timeline. So tell me where you were born and tell me a little bit about your family dynamic, what your parents did, how many siblings.
So I was actually born in Los Angeles, California, in, I would say an interesting multicultural household. So my father is Mexican, my mom is Cuban, my family household is Jewish, and I went to a Jewish school my whole life. And actually my father is a neurosurgeon. So I have sort of medicine in was always sort of around it, like medicine in the household. There was the idea that I would become a doctor like early on, but I actually didn't end up going that pathway. I sort of wanted to carve out my own pathway. And in college, I studied philosophy actually, and was not a pre-med student. And it was only sort of later on in life when I stopped getting parental advice on what to do with my life. I said, on second thought, I think I should go into medicine. So I learned a little bit of lesson from that. Whatever I want my kids to go into, I will not tell them to do that. I'll let them figure it out on their own, and they'll probably come to it sooner than later.
What kind of perspective did you get? Neurosurgeon is such an elite kind of sliver of the medical world. So, what were some of the stories that you heard from your father of how his day at work was?
Yeah, so it's interesting. I think my father being a neurosurgeon had a big influence probably on a lot of my interests actually, and probably apples don't fall far from the tree. So even though I didn't pursue medicine directly right away, we had a similar shared interest in sort of kind of a philosophical approach to the body and biology, and in this case, the mind, the brain, etc. So he had a unique specialty where he would do functional neurosurgery and would basically implant deep brain stimulators, these electrical devices that would be able to rewire the circuitry of the brain and help people improve their function with movement disorders or disorders of pain, etc. And I was very fascinated by that aspect of medicine, more so than I was about the simple biology of medicine. And that's probably what led me towards the path of philosophy, actually. And even after, when I went back into medicine, I actually was gravitating towards the kind of the neurosciences, the brain sciences, the brain medicine fields. And I was debating going into neurosurgery myself or something with imaging. I ended up going into radiology. At one point, I was going to go into neuroradiology before I ended up going into body MRI and now whole body MRI.
So the technology he was working with, would that be one of those examples we've seen the videos of? I believe it's people with pretty extreme Parkinson's and they've got the implants, and when they turn it on, they're able to kind of regain control of their body.
That's right. That's one very well-known indication and application of that technology. So it's funny, if you take a bigger historical view, bird's eye view. So that technique with these brain stimulators was something that was developed probably in the early 90s, became much more mainstream in the early, late 90s and the 2000s. But if you go back in time, they were doing different kinds of procedures for the same concept without the implantable electrical device, but with focal lesioning, often a technique called thalamotomy, where they basically cause a little micro lesion at a targeted region of the brain that would create rewire the circuits in a similar fashion. And the electrical stimulators would basically create like these pseudo lesions imitating that approach. Now, that was always something I was interested in. And when I was in medical school, there was another application that came out, which was called MRI guided focus ultrasound, which is essentially an imaging energy-based modality where you went back in time and did lesions with ultrasound energy the same way they used to do with an open craniotomy and stick a probe in there and kind of target that area of the brain that was misfiring. We can now do that with radiologic-based approaches under MRI guidance, watching them in real time, and then targeting ultrasonic energy to that same region of the brain and burning a small little hole with no incisions. It's like magical incisionless brain surgery. So that was an area that I wanted to go into through radiology, and kind of came full circle towards kind of like what I grew up hearing all about all the time, this kind of rewiring of the brain, philosophical neurosurgery in a way. And I was interested in doing that through radiology. So I actually went into a fellowship after residency to learn that. And I ended up going to Stanford University. The body MRI program had a big division in what's called minimally invasive MRI guided interventional care, MIMRIC for short. And this was one of the leading centers that was basically driving this practice through radiology. Other centers were doing it through subspecialists like neurosurgery in the brain, or in other areas like in the prostate through urology, et cetera. But here at Stanford, we were doing it all through radiology, including we were doing these thalamotomies in the brain with MRI-guided focus ultrasound. Now, while I was in that fellowship in body MRI, I was also exposed to the whole body MRI as a screening exam for cancer screening. And we were doing that in not the same sort of patient population that we're doing at Prenuvo, which is more broad for the general population, but we were doing it there more limited to individuals with certain cancer predisposition syndromes that were at high risk for developing cancer. So that was an area where I was exposed to whole body MRI and found that extremely fascinating, with a lot of kind of forward-looking applications in the field of medicine, because historically, imaging is more relegated towards diagnosing a problem, the cause of a problem once it's clinically pronounced itself. Patient goes to the doctor, doc, it hurts me here, or doctor does a physical exam and palpates like there's a mass on examination. I feel something in the abdomen I'm not normally feeling, or there's an abnormal lab value, and then they'll send it to the radiologist, the patient to the radiologist, to like figure out like what's the cause of that abnormality. Is this something that needs to be worked on, or is this something that can be sort of watched and waited, et cetera? And as imaging had progressed, and now we could do this whole body MRI, it was like a no-brainer that why don't we transform this modality towards the forefront of the patient encounter, the first point, as part of a physical exam, essentially, and then we can, rather than wait for the clinical symptoms to present themselves, get ahead of that curve, and try to be informative to the patient in an earlier state of kind of health status before disease progresses to a point where it's harder to treat and manage. So that was like the thinking that I had at that time, and then sort of I came to where I am now at Prenuvo, sort of, by coincidence, the company was just kind of emerging in the first clinic was in Canada, in Vancouver, and they were just opening their first clinic in the States, in California. And that's when I started getting involved with them at a very, very early stage. Basically, right after fellowship, these ideas were all kind of clicking together for me. So, long story short, what I'm doing here now is a little bit forward looking in radiology, forward thinking, and I think of it more as like a new subspecialty in radiology, kind of like primary care radiology, or in another way of thinking about it, sort of radiology enhanced preventive care.
You mentioned using ultrasound in a kind of surgical way. It's funny because it's not funny at all. My dad just got diagnosed with a very horrendous cancer, and it's not looking good. And the only surgical option is the Whipple, which is to fillet a human being, take everything out, and kind of hope that you can stitch them back together again. But he's been looking at a technology, I think it was hypertrypsy, where they're using it on the liver to target, I think it's the solid organs that it's working with. What is the potential of that kind of technology when it comes to tumors and other parts of the body?
Yeah, I mean, that's an area of, very fascinating emerging field. Basically, this area of histotripsy is one effect that this focused ultrasound technique can have. So you might think of ultrasound of this, it's this mechanical wave-based energy that can have all kinds of effects. And we use it in imaging all the time, where we're not trying to affect the tissues. We're trying to do it in a very low energy way, and in order to get just images of the tissue. But if you can concentrate ultrasound in a way where all that energy comes to a point, you might have an analogy to if you've ever taken a magnifying glass and tried to kind of focus a beam from the sun onto a piece of paper and burn a little hole on the paper. That's what you can do with ultrasound as well. Focus these beams, create high energy. And in one way, you could do thermal ablation, which is what we were doing in the brain for thalamontomy, but you can also do histotripsy, which is where you're basically creating such extreme vibrations that the tissue, the cells themselves basically, burst, and they die in another way, not from heat, but from sort of just high energy vibrations. There is a lot of applications about those in the whole body, and the liver being one of them. I was familiar with the trial that was being done for liver metastases using histotripsy to ablate those in a more minimally invasive fashion. That's a different way of controlling those ultrasound beams than we were doing with a thermal ablation. And there's debates on like what the best way to do it is, but there's really a wide open field for really interventional radiology using ultrasound energy in the brain. Beyond like burning tissue, you can also use it to open up the blood-brain barrier, and that has a lot of interesting applications to deliver drugs to the brain and target all kinds of disease that were kind of behind this wall. Where so in the brain it's a unique organ where like a lot of the molecules that circulate in our blood, they don't have a way to get into the brain. There's a special physiologic structure called the blood-brain barrier, which prevents things from going in. And that's, by evolution to protect the brain in a way. But on the other hand, it's an obstacle in medicine where a lot of the drugs you might want to use to treat, let's say, cancer, chemotherapies or whatnot, and they might go all over the body elsewhere. If there's a tumor in the brain, those same drugs can't get to the brain because the blood-brain barrier doesn't let them in. So with the same kind of idea with focused ultrasound, you can manipulate it in such a way where you basically massage open these the structures that create that blood-brain barrier, and it can make them to be leaky, and then the drugs can leak in there. So all kinds of applications, whether it's in the liver or in the prostate, burning tumors, or in the brain, doing functional neurosurgery, or burning tumors, or blood-brain barrier opening. This is like this is different from Prenuvo. This is nothing that we do at Prenuvo, but that's a whole nother area of medicine that, interesting that you have a similar, you're aware of that and interested in it. That's an area that I trained in and was very fascinated in for a long time.
Absolutely. Well, my dad was a veterinary surgeon, so he's a full-on, science nerd is the wrong term, but he's obsessed with it, and so that's how he first came across it, was researching, treatment options for himself. So
Yeah.
immunotherapy is obviously another very exciting area, but it's not applicable in this particular cancer, sadly. When you talk about medical school, at the front door, it's very interesting because you went more recently than maybe some of the people who have been on here. With the whole cancer conversation, you've got some of these innovations in the treatment side, but obviously the other side of the conversation is, well, the prevention side. What are some of these things that are even creating more cancers in modern society? In the medical route that you went, how prevalent was training on nutrition, sleep, exercise, some of the kind of preventative, holistic elements of medicine?
So, I mean, that's not something I really focused on in my residency in radiology, because we were usually focused on, obviously, in the imaging diagnosis, and a lot of that preventive management is something that would be sort of a different area of preventive care training. That being said, in medical school, I would say that the educational those who determine what should be focused on in medical education at the time, the kind of curriculum planners were starting to become aware of this. So we definitely had in medical school, several lectures kind of peppered throughout training about nutrition and how to optimize preventive disease practices as opposed to just treating the disease. It was still at that time not yet as, I think, big a mainstream focus as it is now. And I was in medical school about 10 years ago, 10, 15 years ago. And like the 4 years of medical school, I did research here for an extra year there. So it was just kind of beginning to get more an area of interest. I bet now if you go to medical schools, it's probably a much bigger focus. But yeah, I was at my time in medical school, it was starting to become an area where we were aware of this, and it was important. We were having dedicated lectures about nutrition, preventive health, the metabolic effects of on things like cancer development related to diabetes and whatnot. So yeah, this is not something new, but something that is becoming more and more an area of awareness and focus and investment in these days.
Brilliant. Well, walk me through kind of the overview of the radiology track then, as opposed to someone who might be a GP at the end of their journey.
So radiology is a field in medicine, and I'm going to focus on diagnostic radiology first. But basically, it's the field of medicine that leverages the kind of the magical abilities of various different energy forms in physics to give you images of inside the body, so you don't have to cut open the body to look at it. Historically, you might think that historically to look, they used to do things like exploratory laparotomies, which may once in a while happen these days, but is not something that we normally do. So usually now, if somebody's has an acute abdominal pain, they'll go to the emergency room, or their outpatient doctor will order an imaging exam to give them the diagnosis. Is this appendicitis? Is this cholecystitis? Is this diverticulitis? It does not require having an open surgery to diagnose the problem in advance. So that's sort of a magic of radiology that's emerged from the beginning of time from the beginning of like the 1900s when they had the first X-ray acquired. And then you move forward into more advanced imaging, cross-sectional imaging like CT scans and MRI scans, which started emerging in like the 1970s, where you could actually get a textbook picture, a slice of anatomy. Imagine like you look at a textbook of anatomy, you see like slices of the body. We could do that kind of imaging with those kind of new modalities. So that's what radiology kind of emerged. Diagnostic radiology is, give the diagnosis to avoid having a very invasive medical procedure to get the diagnosis so that you can treat it. And that's what we basically, we get trained on, all the different modalities. There's X-rays and there's live X-rays, which is called fluoroscopy, where you're dynamically imaging the patient in real time with giving, let's say, a contrast agent that you can see how it flows through the body. And then there's ultrasound there's MRI, there's CT scan. There's another field called nuclear medicine where we give a radio tracer that allows us to image physiologic properties of the body from the inside out. Now, a key feature of a lot of those modalities is while they're more benign in a sense than doing surgery to diagnose a problem, they involve usually some ionizing radiation, which is not a totally free lunch in that if you give too much ionizing radiation to an individual at one time point, or those are not the doses we deal with in radiology, but let's say it's the small doses that we deal with, but you do that frequently over time, that can lead to long-term harm. So that radiation can actually cause mutations in DNA and lead to actually developing cancer in the long run, which is something we don't want to do in a preventive health context. Those are like the historical modalities, the X-ray based modalities or the nuclear medicine based modalities that involve radiation. But there's a couple modalities, ultrasound being one of them and MRI being another one of them, which are unique in that they don't involve any ionizing radiation. And so this became an area of interest in terms of how can we apply those other modalities towards preventive health screening so that we can get sort of our cake and eat it too. How can we get sort of the power of radiology to diagnose disease in a setting where, in a symptomatic setting, the pros of diagnosis usually outweigh the risk. You go one-time CT scan when you have an acute abdomen, it's not going to harm you while getting the benefit to treat a potentially high risk condition will be benefited by getting that diagnosis early on. But you kind of lose that equation when you're like screening healthy people that are not symptomatic. But when you use a modality that doesn't have ionizing radiation, you kind of have you lose that trade-off basically. So for many years, you couldn't effectively do that with MRI because it was a very, 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 very challenging, complex modality. It would take a long time to scan a patient for a small body part, let alone for like screening the whole body. Was extremely expensive. The exams would be intolerant to the patient. They have to lie there for many hours. But as technology progressed and it became more practically feasible, so that's where we started sort of thinking in sort of the Prenuvo mindset of can we put this in the kind of routine, the routine apparatus, the toolbox of outpatient medicine, and that's kind of where we are today. So the technology has accelerated to a level that you can do an effective whole body exam with high quality imaging, get a lot of information. It doesn't come at much. There's no ionizing radiation, so there's no sort of physiologic toxicity to the patient, but it's also tolerable from a comfort perspective. They can lie there for, slightly under an hour on the table. In our case, we set it up with, a way to be distracted. I'm not going to say it's like going on vacation. It's not the most pleasurable experience. You're still lying in an MRI board for an hour, but they're relatively more comfortable than the older, more tighter MRIs. They're a little bit roomier, and the patients can watch like a Netflix movie and be distracted during the time while they're in the scanner. So it becomes a degree much more convenient and comfortable. So putting all those things together, no radiation, no injections, we don't give a dye, any contrast agent, and kind of the time, and then the expense keeps coming down. All these things are allowing us to put it sort of in this preventive healthcare context. So that is kind of taking this like historical view of what radiology was, this diagnostic, especially based on getting images when there's already an established problem, but avoiding an invasive diagnostic procedure, but doing that non-invasively. Now we can do that same non-invasive magic, but go before the symptoms develop. Sort of a little bit of a historical course there, and then toward the subspecialty that we do now.
Yeah, I think it's important just to understand the background and the the whys behind it. Total random question: what is it about the technology that makes it so loud, even with modern day science?
So loud? I mean, for
like literally when you're in the machine, the kind of grinding noise
yeah,
that we're used to in an MRI.
That's due to the physics of the machine itself and kind of the rapidly changing parameters. There's no way yet that I'm aware of to get rid of that noise factor. So even now, like, you're watching in the Prenuvo clinic, let's say, watching a movie, and you're listening to the movie, you'll still hear the noise through the headphones. But, we'd give people earplugs to try to dampen out the noise, and then the kind of headphones on top of those so they can hear a movie. That will help a little, but they'll still be pretty loud. You can't get away from that, unfortunately.
Brilliant. What about where we are today as we have this conversation in 2026 versus, as you mentioned, hours just to get a little sliver of the body, a couple of decades ago? What can you see now with this head-to-toe scan that people will be hearing about?
We can see a lot, and we can get a sense basically of someone's general state of health by what we see on the MRI. It's not going to give us all the information. There's going to be a role for things like labs, history, risk factors, et cetera. And that will put sort of a lot of our imaging observations in context, as well as fill in voids where we can't give complete information from the imaging alone. But all that put together allows us to get sort of an integrated approach to giving personalized sense of that patient's health, and then give them guidance to what they should plan to, for the next year, 5 years, 10 years, et cetera. Low-hanging fruit, I would say, is kind of the tumor screening. Obviously, that's an area of main interest for a lot of our patients and referring doctors. If you look at the current state of kind of recommended cancer screening, there's only about 4 specific cancers that are actively screened for in a targeted fashion. And it's limited to certain patients fit a demographic profile above a certain age with certain risk factors, which leaves a lot of people that maybe don't fit that demographic, or that may be at risk for another cancer that's not one of those 4 cancers, sort of at some degree of risk for having a tumor develop that will go below the radar until it's kind of like later on in the stage of that tumor. Now, these might not be necessarily the most common tumors, and they might not be individually very high risk, but when you take them as a kind of totality, they actually make up most of the cancers that are diagnosed. So actually only 14% of cancers are diagnosed through screening in today's day and age. So this is sort of a unmet need still, this sort of multi-cancer detection strategy. And so what you can think of, what one important void that something like the Prenuvo scan fills is this. It's an imaging-based multi-cancer detection tool in a sense. It allows me as a radiologist to examine the body head to toe through images, and anything that's basically forming a structural lesion, a mass-like lesion, essentially that could be a tumor. That can further characterize, is this an aggressive-looking tumor? Is this something that looks benign? Is maybe not even like something to worry about? I can characterize these into buckets of concern. Don't worry about it. This is an intermediate. Let's follow this up a little bit more actively, and watchful waiting. Maybe see you again in 6 months. Maybe see you again in a year. Or maybe this is something that needs immediate attention and intervention prophylactically now. So we can bucket these types of observations and that may be tumors into these different levels of concern, and go do it head to toe. So whereas traditionally there's only breast cancer that's screened, colon cancer that's screened, cervical cancer that's screened, in smokers that are of elevated risk beyond a certain age. We do low dose chest CT screening, and even prostate screening has some controversy. It's usually done with PSA, a lab test. Some societies are for it. Some societies think it's a little bit diminishing returns. Those are the limited really cancers that are actively screened for. But for everything else, we're really sort of in the dark about when we should be informed of a diagnosis, and what you do about it is kind of tailored to a patient specific context. So not everything needs an active emergency type alarm to it. A lot of findings that we encounter can be watched and waited. So that's important to realize as well. It's sort of a risk stratifying practice. That's from the tumor screening perspective, but separate from tumor screening, this is really not limited to tumor screening, because we're doing the radiology, the cross-sectional imaging. So we get a lot more information beyond sort of a cancer risk score in a way. So we include pretty high quality, high resolution imaging of the brain. And if there's concerns for things like demyelinating disorder, like multiple sclerosis, we can find patterns that would be concerning for that, and then trigger appropriate follow-up for that kind of condition. we screen for, we do special sequences in the brain where we look at the brain arteries, actually, the flowing blood going into the brains. And this is done just by tweaking the parameters on MRI, no dye or anything like that. One of the magic things you could do with MRI that you can't really do with CT. And we use that very commonly to screen for aneurysms, so brain aneurysms. So we do see a good amount of aneurysms, actually. They're often small, low-risk aneurysms for which we don't recommend that every person needs to go, get that treated. But we like to follow them to see which are the aneurysms that are starting off small, which one is going to stay around stable and not going to grow and pose any risk to somebody versus ones that are progressively dilating. Those ones will trigger a prophylactic, consultation probably with endovascular neurosurgical specialists or something like that. And many of those will probably get treated because we want to avoid a catastrophic event like a ruptured brain aneurysm, which can be basically a sudden death type episode, or if you survive that, can cause significant morbidity and cost over someone's lifetime. So brain aneurysms, that's another sort of high yield area that we screen for. Brain neurological disorders in general. And then in the body, all kinds of metabolic disorders. We focus a lot on the liver, things like fatty liver or hepatic steatosis, something that a lot of people in America these days are walking around with and don't even know about it. It can be related to diet, can be related to genetics. And we can see that very well with MRI and quantify it and say, this is a mild level, this is a moderate level, this is a severe level. And if that goes sort of undetected and unmanaged, it can lead to things like liver disease, inflammation in the liver, even in the long run, fibrosis and cirrhosis. So getting ahead of that in advance, you can manage that with lifestyle changes, improve your diet, and we can see again, how's the fatty liver changing. If there's elevated liver enzymes, you might need to go for, more targeted attention to like a hepatologist that might want to treat the inflammation associated with fatty liver. Are there sort of liver toxins that you're ingesting, or change your drinking habits and things like that? These are things that will give more kind of impetus to a patient that may not be thinking about these in advance to like want to act on it. So in a way, a picture speaks also 1,000 words. And we've seen this anecdotally in our practice, like patients will know that they need to kind of improve their diet or kind of cut back on their drinking, but they've not done it. And then we show them like, look, this is your liver and this looks really fat. This is going to keep getting worse. And they'll use that as, oh, wow, now I really am motivated to improve that because I can see that myself. So tumors, aneurysms, as I mentioned, metabolic disorders like fatty liver, these are sort of examples of the wide spectrum of conditions that we can assess for on a whole body MRI examination. And it's really a risk stratifying approach. It's information that we can provide that can then be put in context and inform next steps on how to optimize health in the short term or long term.
So you guys were kind enough to allow me to come and do an MRI myself. And I was incredibly impressed by the depth of the family history questionnaire prior and my own personal history. Very, very impressed. And for everyone listening, I haven't been paid to say any of this stuff. By the actual clinic itself, the place where we did the MRI, really, really great experience. Very thorough, like you said. It's the most encapsulating MRI I've ever done. And I've had MRIs on my back, on my knees after injuries. And then after, the consultation, so you get, the results, and it was very, very quickly as well. But it was, I think we talked for an hour in the end and went head to toe, all the different, systems and organs and, the musculoskeletal system. And it was so incredibly thorough. And when I think the application of the fire service or the first responders listening, it in itself is incredibly powerful. But if you have a baseline, whether it's the first day, firefighter, cop, whoever it is, or whether it's, now someone's 25 years into the fire service, which is their first one, the ability to scan and detect, God forbid, an abnormality in a blood vessel or some sort of tumor in itself is incredibly powerful, because as you said, normally we're not going to hone in on it unless there's symptoms, because most departments don't have thorough blood work either. They're very kind of surface level. But where I see the superpower of this is you've had your baseline, and in medicine, obviously trending is the biggest thing, is the second scan. there's a couple of places where I had a blood vessel and it's probably just thickening genetically, but it's something that I'm going to look. And when I get it done, a year or two later, now I'm going to be able to compare, 2026 and 2028. And I think that's where there's incredible value, because now, as you said, you can see, was this a benign genetic non-abnormality? It's just I'm abnormal in my anatomy, or is this a growth or a weakening of an artery that I need to be worried about?
Yeah, that's a really important point. So the idea, the highest value will be for an individual will come from using something like the whole body MRI as a longitudinal surveillance tool. And it allows the individual then to basically serve as their own reference control. You get the baseline in hopefully a healthy state. Hopefully on the first scan, we don't find anything that is particularly radiologically concerning. Like, we'll see a lot of benign. Nobody has a completely normal whole body MRI that really doesn't. That's sort of like a paradox in a way. It doesn't exist. Like, everybody has dots all over the body. You might think of it as an analogy to, like, look at everyone's skin. Like, everyone has freckles somewhere. You don't go to the dermatologist and they biopsy every freckle for possible melanoma, but they can recognize the ones that maybe are more concerning, that need watchful waiting, or the ones that need a biopsy on the spot. So you now go deeper into the body, and everyone will have things like, little dots and little cysts, and say the kidneys or the liver, things like that. Those are sort of leave alone, but we can document that the baseline, and then serving as someone's own control. What is normal for them is basically what are the expected age-appropriate changes that that person might develop within a year or two. There are things that, from seeing so many healthy whole body MRIs, we have a sense of this is within the spectrum of normal versus this is outside the spectrum of normal, and this requires some tailoring, targeted attention in that specific patient. It's not all just about tumors and aneurysms. It could be, you mentioned, spine imaging could even be something about spine health. So, there's a lot of wear and tear that we all get on our spine. No one's going to escape. The radiology term we use is degenerative change of the spine. That really means, wear and tear. Now, you can be somebody in their 50s who has the spine of a 50-year-old. That's maybe age appropriate. You could be someone in their 20s and has the spine of a 50-year-old, and that you might not have any back pain issues right now, but you might want to be alerted to that so you can practice good spine health, good posture. If you work at a desk, maybe get ergonomic type desk setup, standing desk, good chair, etc. Do appropriate exercise and manage, your weight to avoid the accelerated deterioration of the spine, so that when you're in middle age, you don't have the spine of somebody who's like in advanced age. And maybe when we all get to advanced age, maybe on the other hand, if we can be mindful enough of our, physical mechanics better, we might be in our 70s and have the spine of a 50-year-old. So that is sort of the idea. Getting this imaging information is a motivating factor towards optimizing long-term health. Now, tumors, obviously, those are important because we will often see a smaller locally, like a local tumor that's will never have pronounced itself until diagnosed for another reason once it's much bigger and harder to treat. But when you see with imaging at the earliest stages, where it's just it's a nodule in an organ, and it's new from, let's say, last year, and it doesn't look like the benign picture of a cyst or some other typical benign thing like a hemangioma that we often see in different organs, then this is basically an alert to early action. And many times those don't need to be aggressively treated with a major surgery, let's say, but we have the tools to observe them minimally invasively, either with more imaging or to even intervene on them without having the morbidity and risk associated with like big open surgery. So, an organ that I'm particularly, excited by in my case is kidneys. Kidneys, we actually see a good number of early renal cell carcinomas. And there's probably some controversy about those. Like maybe we're detecting a lot more renal cell carcinomas than that really would never have hurt the patients had they not been like detected with imaging. Maybe they'd be slow growing, relatively indolent, and a patient might die from some other cause in like 10 years, and better they didn't know about it, but rather than know about it. However, that's sort of based on, I think, incomplete assumptions, because not every small tumor needs to have a major surgery and take out the whole kidney. So nowadays we can minimally invasively with imaging, put a needle into that tumor and ablate that, like we were talking about earlier with focused ultrasound in the brain. Similarly, you could do, whether it's with, not so much these days with an ultrasound, but maybe in the future with something like histotripsy or another ultrasound too. But these days we usually do it with like a needle-based ablation with radiofrequency or microwave ablation, and you could leave the whole kidney intact. You just burn the tumor, and that's just the disease tissue is removed. And the benefits are that you kind of get the benefit of early detection without the cost or the trade-off of the unintended consequences of the high risk and highly costly treatments that would go along with that. So the technologies are kind of emerging in parallel: medicine from the interventional side, as well as medicine from the diagnostic, as well as medicine from the pre-diagnostic but early detection side. So the baseline really enables you to use your own self, your own data as that control. Because if I see a new lesion, small, maybe looks low risk at the first baseline without the prior baseline, I might not be able to tell you, oh, this is more concerning, because I want to see another time point. But if I already had an earlier time point where I can see it wasn't there, and now there's a new tumor there, that means I can give you a trajectory of like sort of, this is number one new, what's the growth rate, what's the doubling time. This has more concerning for something more progressive versus something stable. Now, if I see it for the first time and I see you again in 3 months or 6 months, and I can demonstrate, well, look, it hasn't grown, actually, it's stable, we don't have to really worry too much about it, so we can afford to watch and wait it. So those longitudinal data points are more additional information that people forget about. Like, that value is really in that longitudinal follow-up, goes beyond just the baseline alone. And the ability to do that without ionizing radiation means that we don't have to worry about the concept of overdosing people with the trade-offs that we would get in other radiology contexts that would also, in theory, be able to do the same thing, but come at that radiation cost.
I had a guest on for a second time, Josh Clemente, who's the man behind Levels, and he made a really powerful kind of point. He said, and he was obviously generalizing, but he said doctors were never meant to be treating chronic disease. He said doctors were originally created for trauma and, childbirth and some of these other areas where you need this medical professional with this medical expertise. And with this AI and with, the much better blood work now and technology like, preventative MRIs, his point was, we're putting the power back in the hands of the patient. Now we're asking medical professionals to interpret this data for us. But now you can say, okay, I'm starting to get slightly fatty liver disease. Before I ever would have walked in, because now I'm bright yellow and asking my doctor what's wrong, now I'm so far ahead of it that I can look at all these things and say, as James Gearing, as my own, advocate, what am I going to do to get ahead of this? And we don't really have that in a lot of modern medicine. People go when they're already feeling bad or they're already hurt. And I'll give you a good example. When I had my MRI, and I wish I could remember your colleague's name, that was the one that was walking me through it. But she was saying how good my spine looked. And what was interesting is I had a near career-ending back injury about 10 years ago. And even though I was told to take meds and probably go down the surgical route, I refused and did chiropractic and specific movement practice that is amazing for back health. And my back looks great. Even like the actual disc, the bulging of the discs had gone down. And I hadn't really had an MRI on my back since I originally heard it, which at that point there was multiple protruding discs and one of my vertebrae was turning the wrong way. So it goes to show that now you have this kind of imaging proof, like, okay, you're not going to go back to having an 18-year-old back, but yeah, in that particular case, movement practice helped my back without any surgery. You reverse some areas in the body by changing your exercise routine and your sleep routine and your nutrition. So what I love about this is not only obviously the screening itself, but it's putting the power of the patient, back in their own hands, which is the whole point. They're the only person really, apart from their family, that's affected by this health. So the more we can empower them with this modern technology, the more they can understand this whole issue, the more empowered they are to make their own decisions. And then most importantly, that proactive preventative health becomes a lot more powerful now.
Totally. So it in a way, it democratizes the medical data and makes it accessible to the patient direct. And it's not limited to, the whole body MRI, a Prenuvo scan alone. Like nowadays, patients have access to their own medical records relatively generally, right? The challenge is a patient may also be overwhelmed with all that data without sort of kind of, like you said, like originally medicine emerged as sort of a way to treat acute disease. But at the same time, even outside the acute setting, you kind of need an expert coach to kind of make sense of all this data for you that's often can be very technical, or maybe you might be, well versed in one area of it, but you don't understand how it integrates with another area of, like, how does imaging relate to labs, et cetera. And so kind of having a medical expertise to holistically integrate this and counsel you. So counseling, I think, is going to be very important nonetheless. I don't think it will be any one individual can be assumed to, it would be sort of irresponsible, I think, of doctors to sort of say, here's your data and go figure it out. But it is our job to educate, counsel, and provide guidance on how to use that information. But the patient then, once they have that framing, is then armed to take care of their own health in a way that is not behind sort of the gates of medicine. You don't have to go to any one center or doctor who's sort of controlling all the data, and then having the doctors talk to the other doctor to share the opinions of the data. It can all be centralized in really the patient as the concentrating point for their own data and healthcare. And that's something that we've done at Prenuvo specifically. We had that in mind. And so every patient through like the Prenuvo app will get the full set of, the radiology report for sure. They'll also get sort of direct embedded links to sort of educational materials for any one of those conditions that we may be observing, whether it's the fatty liver or the liver cysts or hemangiomas, et cetera. Be able to put that in their own context, in addition to having the medical consultation that you experienced, but then also have the images themselves downloadable through the app that they can then share directly with the specialist that they go to. So they can go to, let's say, the liver doctor, and the liver doctor can download the images and look at them directly themselves, and then have the maximal exposure to the pure data, and it not having to be filtered through multiple kind of playing telephone in a way. And the patient takes ownership of their own care because they could choose their providers. They can connect the data directly to the provider, and I think that's been very well received and very, very useful. Nobody is more of an advocate for their own health than themselves. And having been in the medical environment as a patient myself, and for my wife when she was delivering our kids, everybody needs to be able to advocate for themselves. And the more knowledge that you have and information you have at your disposal, the more it arms you to do so. Especially as the system gets bigger and bigger and bigger, and it's hard to sort of, we lose a lot of that personalization that is important to the sort of the tradition of medicine, that patient-doctor relationship. So I think this new development of democratizing medical data and making it directly available to patients and arming them with that information is important, especially as we just keep making it more accessible to the larger masses. People need to be able to advocate for themselves and have that direct touch on their information.
Another application that I'm thinking of in my mind, just as you're talking, even at my level, at the bachelor's level and the paramedic school, when we're taught medicine, it's organ system by organ system. Okay, this chapter is a renal, and then I would imagine as you go through medical school, if you have a residency and a specialty, and now you become a renal specialist, there's a danger of becoming myopic in that one area. when you have the ability to then have all these images though from a full body MRI, and you think this issue is coming from the kidneys, but you're like, well, I wonder if it's coming from this other area. And now you're able to look at the whole body and say, well, was there an issue with the liver, or was there some cardiovascular issues in the lower legs, whatever it is that you're looking for. And I can tell I'm just making that part up because I'm not a doctor. But getting that macro perspective of the whole person again, I could see there was value when trying to even diagnose something when you have gone to that specialist.
Yeah, and even in radiology, it takes some wrapping your head around, because in radiology, usually we would, outside the whole body screening context, usually you'd get like a brain MRI or a prostate MRI. These are totally separate organs. They don't like interact with each other. They're not diagnostically related, but it's not really true because they're all part of the organism, the whole body, entity. And a lot of these conditions and pathologies have in organ systems, they interrelate with each other. So obviously, when we talk about the heart, the kidneys, the lungs, the liver, these are all physiologically related with each other, and you can have fluid dynamics and physiology that affects all those organs, or systemic conditions like inflammation or even cancer, that you might have a tumor in a certain organ, then you have metastases spreads elsewhere. Until you take the whole body approach, number one, you can sort of characterize distinct processes that are separated in anatomic space in a way, but a lot of times they do interrelate. So when you see somebody with, let's say, a picture of metabolic syndrome, they have enlarged visceral fat. So when I talk about visceral fat, I mean there's like two general categories of fat. There's like subcutaneous fat, the fat below the skin, which is maybe aesthetically not the type of fat that we want to have, but from a metabolic perspective is not like the bad metabolically dysfunctional type of fat as much as visceral fat is. Visceral fat is like the deep fat, usually within the abdomen, but also can be in the chest, the thoracic, pericardiac fat. But these are the kinds of fat that will go along with things like sugar dysregulation, diabetes, and things like that. They'll often be part of a manifestation of a metabolic syndrome and fatty liver, and can also be related to all kinds of chronic vascular disorders. So, diabetes can cause, small vessel disease. So in the brain, we might see small vessel ischemia, a little, what we call nonspecific white spots, but it's often a kind of small vessel ischemia from long-term sort of narrowing of those end small blood vessels. And you can grade it in terms of mild, moderate, severe. And as you can see, get a more general whole body picture of not just this organ is diseased, but how does this organ manifest in a sort of whole body system with integrated systems, and get a sense of this. So we might say, oh, well, you might want to get more aggressive management of your cardiovascular risk factors because, look, you're on the verge of showing signs of metabolic syndrome. You have increased liver fat, you have increased visceral fat, you have end organ ischemic change in the brain, etc. You're in your 40s. Let's think about this so that when you're in your 60s, you don't have increased risk for cardiovascular, acute events, or even brain health like vascular dementia, which can lead to over time of one kind of dementia from just brain small vessel ischemia that just goes unchecked and keeps progressing. Now, it's not going to be a magic bullet. These are informational findings that will give a patient sort of impetus and maybe give them a benchmark from which they can compare future changes over time. And as long as things are improving without getting worse, that's probably in many cases the best that we can hope for. But there are targets like the liver fat that we can see, you're taking fat off the liver, or visceral fat. The visceral fat is decreasing. And so your general trajectory might be improving. So in another sense, another kind of interesting application to make it easy is from a tumor screening perspective. Cancer screening is often like binary tests. Is there cancer? Is there not cancer? And it might be in an organ limited fashion. Like with the PSA, we're looking for prostate cancer, or in breast, another imaging modality targeted just for breast is mammography. Which, on a side note, I just want to clarify, when we talk about these multi-cancer detection technologies, these usually are not intended to replace any one single cancer screening approach, because those are evidence-based to be highest yield for patients of certain risk factors for that kind of cancer. So they complement each other. But that being said, usually they'll be focused for, is there concern for cancer in that one organ, binary, and then a patient will have to undergo other examinations to, let's say, cancer is proven. What's the sort of burden of disease? How big is the tumor? Where is the tumor located? Is it on, which organ of origin is it from? Which is it on the right side? Is it on the left side? And is there evidence of local invasion or distant metastatic disease? So those sort of staging evaluations are often, additional exams after the fact, and those will have a role still, no doubt, after, let's say, a screening detection with a whole body MRI. But you can imagine we will also get, at the time of screening, the same encounter, the detection, but also an estimation of disease burden, because we're getting that whole body view. So I might be able to say, oh, there's a prostate lesion, but by the way, and that's very concerning for prostate cancer. It looks like, we grade it on sort of, MRI features, and I say this looks like cancer until proven otherwise, needs a biopsy. But by the way, there's also all these bone lesions, and those look like prostate metastases. This might be considered high, late stage cancer until proven otherwise, which changes sort of maybe the aggressiveness with which you work it up and treat it, or the treatment options, or sort of the goals of care. And you can get that at the same time point of screening that you wouldn't get with other kind of non-holistic approaches to the whole body. So almost all diseases that we are concerned about will progress towards sort of systemic manifestations, but our goal with early detection is to detect them at a local stage. But if there is evidence of systemic manifestations, be able to get a sense of that as well. So it's kind of like a lot of bang for your buck in the early detection space, because we get that systemic view at the same time as a byproduct, really, of the early targeted detection.
What about the skeleton? Are you able to see bone density or, potential fractures, etc.?
So that's an interesting area. I would say that's talking about bone density, not something today that we are doing. I wouldn't hang my hat on that, but there is research that MRI at some point should be able to get developed and become clinically mainstream enough to be able to do some form of bone mineral density assessment. Now, that's not where we are today. So you come to Prenuvo, you would not get sort of an osteoporosis screening, but there are individuals, researchers looking into being able to do that sort of opportunistic sort of detection with MRI as well. So it would put kind of bone mineral density aside. If someone, let's say, usually females over a certain age that are at risk for osteoporosis, they should probably still go for this usual DEXA-based screening, which allows to measure the bone density relative to age match controls, and see if they're at risk for getting more at risk for getting a fracture. So we definitely don't want someone to replace that practice with anything we're doing with whole body MRI today, but there would be potentially some applications in the future. So put that aside, the bone mineral density for now, but talking about, let's say, fractures. If someone had a trauma, they fell something, or they have an unexplained pain in a bone or a joint, I don't want them to come to Prenuvo scan to diagnose that, because there'll be a more directed diagnostic modality in that setting. But if somebody has a history of fracture and they didn't even know about it, it's chronic at this point, let's say in the spine, they previously had trauma, and they know about it, or they don't know about it, and there was compression fractures, or they have osteoporosis and there's compression fractures, and maybe they didn't know about it, we can see manifestations of what looks like chronic compression fractures. We might say that there's no evidence for acute findings. There's no edema. There's no spinal canal stenosis or cord compression or anything like that. But usually these would be chronic, but we can give a sense of they are there present. So that would be something we could comment on, but I wouldn't recommend that that's something to come to Prenuvo for, because usually those are things that would be diagnosed routinely in more acute settings, or with a bone mineral density in sort of the standard screening context.
I want to go to some of the success stories that you heard, but just before we do, my profession is known. Sadly, cancer is a big thing in our profession. We have carcinogens in the fires that we respond to, and a lot of the other hazards. We have carcinogens in our gear, like PFAS. That's actually in there because of the manufacturer. We also know that sleep deprivation is carcinogenic, which is a more recent revelation. Let's put it that way. We have the heart disease, and again, from the stress to the body composition. But one of the ones that's been alarming recently is a lot of young firefighters getting strokes, and a lot of them are hemorrhagic strokes. With obviously your father, and then now yourself, what, if any, have you seen, read about as far as the correlation between shift work, chronic sleep deprivation, and that kind of disease process in younger men?
So I want to not oversay what I'm not an expert on. So I'm not necessarily specifically informed on the firefighter-specific risk factors for developing stroke and young men for developing stroke. That being said, all the things that you mentioned, these are known risk factors for all kinds of significant disease, including cardiovascular disease and stroke risk. So I'm not surprised that firefighters as a group would be at elevated risk for developing things like stroke, in addition to their risk for developing all kinds of tumors that are at higher risk than the standard population. But as a matter of, can I say, do I know more about like this causes them to be at more risk, this particular practice or this material that they're exposed to, or in their gear? That is not an area that I'm particularly informed on. But I will say that I have a good amount of experience doing whole body MRI in firefighters. We see a lot of firefighters at Prenuvo. A lot of departments are actually referring their members to us for advanced screening. Oftentimes, the first thing that I'm aware of that they're interested in is the cancer screening. I actually was less aware about the cardiovascular concerns. That being said, we can provide a lot of information that would inform risk assessments towards that. So if I see examples of prior strokes that may have been subclinical stroke, we can give that information on the whole body scan. If I see evidence of risk factors like small vessel ischemia, like white matter disease and whatnot, even if no like large vessel occlusion or vascular territory stroke had occurred, this is one data point that says this patient is a vasculopath and probably should get into some a preventive care program to minimize their ongoing risk, not just for brain, but for cardiovascular events as well. The two will go hand in hand. If I see things in the brain, you mentioned hemorrhagic stroke, that could be various different kinds of stroke. If it's a hemorrhagic stroke, meaning maybe one type being from a ruptured aneurysm, we would see manifestations of aneurysms, pretty well, probably as good as one would hope for in a pre-acute scenario, which allows you an opportunity, to do surveillance on that, or even prophylactically intervene on if it's beyond a certain size. You have risk factors, familial concerns, etc. Those patients might go for an early, hopefully relatively minimally invasive intervention as well. Now, those would be like subarachnoid hemorrhage from an aneurysm, but there could be other types of hemorrhagic stroke. It could be from hypertension or other etiologies. I'm not going to probably be able to predict a hypertensive stroke because that is going to be acute, and shown probably from a history of hypertension. But again, those are data points that will go together. If a patient knows they have high blood pressure, and maybe that wasn't itself like something that motivated them to, get into a blood pressure control improvement plan, but I show them all these other data points. Oh, look, you also have small vessel ischemia. That's also related to hypertension plus minus diabetes, or you have these, metabolic disorders with increased visceral fat and fatty liver, et cetera. The picture is not looking like it's going in the right direction. The picture speaks 1,000 words and has been very helpful for those patients. We can also see if there's, I want to soften this a little bit, sort of like, significant atherosclerotic disease in the intracranial arteries. If there's like high-grade stenoses. Usually, this is not the first line approach for kind of screening for atherosclerosis, but if I see sort of irregularities in the brain arteries, and this could be suggestive of atherosclerosis and higher risk for, developing future strokes, I might comment on that, but usually that's not the first way we look at that. So I don't want someone to think that they can get a Prenuvo scan and have sort of no comment on like atherosclerosis or narrowing of the brain arteries and think that means they're risk-free. But we might comment on that opportunistically if we see that. Similarly for like dissections, which can be a cause of stroke as well, if we see sort of weakenings in the blood vessel wall where it's now starting to kind of tear off some of the inner lining of the blood vessel, often from hypertension or from some, let's say, neck manipulation. We see that once in a while as well. And we might say, oh, there's concern for dissection. We need to further evaluate this and see somebody to evaluate if there's any risk for stroke or symptoms, and then treat the risk factors that may go along with that. So it can heal basically and not have an acute event. So these are things that are like opportunistic, but the main thing that we screen for kind of neurovascular wise would be brain aneurysms.
And one area we didn't really touch on was the heart specifically. What are you able to see with the heart?
So in this kind of the current iteration of the Prenuvo scan, and I emphasize current iteration because this is always an improving exam, an improving technique. So we will hopefully improve our heart evaluation over time. But right now, because the heart is a moving structure, it's beating, there's some blurring of that organ relative to the static organs that are not in motion. You might think, obviously, if you're taking a picture of somebody and they're running around, they might be blurred. So the same kind of logic applies by analogy in kind of medical imaging. So because the heart is beating in motion and we didn't do any special tricks on the Prenuvo scan that you might have in like a cardiac MRI where you're doing kind of cardiac gating, where you're timing the imaging to a certain point of the cardiac cycle where you can control for that motion and kind of the state of contraction of the heart as well. We're not doing that in our screening context right now. So the heart will have some relative limitations. So it's not going to be an exam that can really tell you much about heart function or the kind of coronary arteries or many of the relevant, important structures that you'd want to know about from a more complete evaluation, from a preventive mindset about heart health. That being said, if there's a big abnormality, like a mass around the heart or a lot of fluid around the heart or a gross enlargement of the heart, we would comment on that. If I see related not to the heart itself, but let's say to the vessels coming out of the heart, the aorta, if I see the aorta is dilated, I might comment on dilation of the aorta and risk for aneurysm. That goes for the thoracic aorta in the chest, as well as for the abdominal aorta in the abdomen. So those major cardiovascular structures we can provide some comment on, but as much as like a detailed evaluation of the heart, this will not be the first line for that. So for, let's say, coronary artery evaluation, there's better techniques for that right now. And if someone is interested in sort of heart function and looking at the heart valves and looking at the ejection fraction of the heart, how much it's pumping out, then something like a echocardiogram is going to be more standard and more informative to that from that perspective than what we can currently do with the Prenuvo scan today.
So the chief of Boynton Beach Fire Department, Hugh Bruder, not only was part of the movement to move them to a healthier work week in the fire service, 24/72 we call it, which is a 42-hour work week. They also use you guys. I think it's every 2 years they do a scan. And he was singing from the rooftops about how incredible it was. And he talked of several lives that were potentially saved through this technology. We don't have to talk about that particular department, but in general, talk to me about some of the incredible success stories you've had with this preventive medicine.
So hard to talk about specific individual stories without risking sort of, talking about and violating kind of patient confidentiality. But I can tell you, like, a big picture, we've had a lot of positive feedback similarly from the firefighting community. We have a program, we call it the Warriors program, that kind of acknowledges sort of the additional risk and and appreciation. So the risk that firefighters and other first responders and veterans kind of put themselves at for the benefit of basically everyone else in society, and acknowledges that and wants to demonstrate that we want to deliver this kind of service to those that need it most potentially, and appreciate them for everything that they sacrifice. So we have a program like the Warriors program that allows it to make it easier for firefighter communities to come and get scanned with us. And we've had a lot of very positive feedback, whether it's an early detection of a tumor, whether like a bladder cancer or brain tumor. We've seen these examples frequently, early detection of an aneurysm. We've seen these, these stories come back to us with gratitude, saying, wow, if it wasn't for this, I would be at extreme risk and, put my team at risk if I had a ruptured brain aneurysm in the field, or my family at risk, et cetera. So this is something that I think affects firefighters at least as much as our regular patients, even more so because of the added responsibility that they carry and the risk that they put themselves at. We're collaborating in that's the Warriors program, but we're collaborating in a firefighter cancer screening study as well. So we're not the only ones interested in this, but we have partners in the community that are clinicians in this particular study based out of kind of the Maryland area, that they're running a firefighter cancer screening study looking at, can we offer actual benefit to firefighters with early cancer detection, going beyond sort of like the N of one? Like, we know we can affect individualized, but does this affect with benefits sort of like the group level? Can we justify this from a broader active screening perspective? So we have a very, active program that we're collaborating on over there out of the Maryland area with the Innova Health System. And that's ongoing. So I don't have like results that I can share about it, but these are definitely we started off with the anecdotal stories, and then that gives us reason to want to investigate things more robustly in a scientific context. So that's where we're kind of moving towards right now, establishing more scientific methods to study the benefit to groups like firefighters, especially.
Well, going back to that one department, you take your work week to a healthier work week. So now your men and women are getting more rest and recovery. Then you put in, ideally from day one, a baseline, full body MRI, and then, every year, 2 years, whatever it is, you're putting that in as well. And you have comprehensive blood work. And I know your colleague was talking to me about the potential of even doing an ultrasound as well as part of the overall test to hit some of the areas that they are better at hitting than the MRI. And now you've got the ability to get ahead of so many of these issues way before they become acute, potentially. Of course, there's always those anomalies, but to me, this technology seems like if it was interwoven into the fire service, I mean, firstly, you'd save so much money catching these before they became, God forbid, some, hundreds of thousands of dollars chemo treatment or, neurosurgery. But also, more importantly, you're empowering the firefighter to stay ahead. And then, as you mentioned, even with body composition, when you start to see that fat is actually very visceral, you can show the pictures to the firefighter, and then that will definitely help, hopefully motivate them to start curbing the way they eat and exercising more and that kind of thing. So I see so many different applications from a prevention point of view, rather than what we normally see, which is reactive. Our whole profession, that's the nature of the beast. As someone calls 911 and we react to whatever we go to. Well, the other side of the equation is, how do we stop people's homes burning in the first place, people having heart attacks in the first place? And this gives us the potential to do that same thing to our own health.
Yeah, I'll add on to that. I think, and it may not be surprising, but from what I've seen, the firefighting community that I see at Prenuvo, they seem to be I think an objectively stoic bunch. I mean, you guys are tough. And so a lot of times the kind of observations that I see in firefighters, I'm like surprised. Wow, how are they not complaining of this, of being symptomatic? Whether it's like a musculoskeletal injury, like a muscle tear, or a degenerative spine issue, like very tough guys kind of suppressing a lot of the physiologic symptoms of stress on the body to get the job done, but it puts their own well-being on the side, because it's hard to focus on that when you're running into buildings and doing whatever you have to do to, lift somebody out of that state of danger. And at the same time, you're overcoming the sensations of pain or something in that body part that is telling you, oh, don't lean on that knee or something like that. You just ignore that. And then, the acute pain subsides, and then it goes back to normal, but that doesn't mean the body has totally healed. So we see this all the time in imaging. And I talk to, some of my, referring colleagues who tend to refer us these firefighters. I'm like, wow, these guys are stoic, right? I don't understand how this is even in the screening context a lot of the time. This is stuff that if my body looked like that, I feel like I'd be in the doctor complaining like a little baby myself. So the view into the body, it gives kind of like those of us that are tougher than others from like our body is still not foolproof, even though we may be able to mentally overcome the pain in the short term. And it allows you, when you're not dealing with that emergency situation and having to, take someone out of the burning building, to like refocus on yourself and say, oh yeah, I got to really work on that PT for that knee injury that I had, or, my back that it does kind of ache me a little bit, but I can like brush it aside. Then I point out, oh no, look at that big disc herniation over there. Maybe you got to do some more active, take it easy. Don't you do some physical therapy. Let's let things go back to the way they're more physiologic. So I think the imaging information arms, especially people like probably firefighters that have to suppress a lot of those internal triggers, those cues that there's something to, pain is good. It tells our body, like, take it easy on that part of the body, allow it to heal. And some of us aren't as in an environment that allows us to do that routinely, while some of us are. So I think firefighters are a unique group that could benefit from this proactive health information, body information that is not really accountable in a routine preventive healthcare context.
In the mental health conversation, it's been interesting because my mind has shifted from 9-10 years ago, which was, man, we keep taking our own lives. This is addiction crisis. We're air quotes broken. How do we fix us? And then over the years, from the resistance through the conversations to understanding what psychology looks like in high performers, you realize that really the conversation we should be having is actually performance. Because if you do the things that forge mental performance, you are simultaneously addressing the issues that affect, negative mental health. And I think this is the other part of this conversation is if you have first responders who are proactively staying on top of their health and the injury prevention, all these other areas, you will perform at a much higher level. As someone who has nursed many injuries through my career before they were addressed, you are operating at a lower percentage. There's just you cannot deny that. So I think from a performance point of view, where do we take the fire service? Where do we take law enforcement ultimately? This kind of proactive preventative screening allows you to get ahead of all the things that are going to hold you back, address them early so that you can carry on performing at a high level.
Yeah, no, I think that also makes a lot of sense. It's not just for the firefighter, the individual themselves, but the team, the society benefits from maintaining the optimal health, performance health of the individuals on the team. So it's mutually important to value this perspective of preventive health. The team is only as strong as the individuals that make it up, right? So if not everyone is performing at 100% because they're nursing an injury or they're struggling with a mental health issue, this needs to be addressed sooner rather than later when they are actually more addressable, and you can change the trajectory of the course of that limited condition, but also then how it affects the individual holistically, and then by extension affects the team. So it's really multifactorial. Totally.
Absolutely. Well, for people listening, I'm sure they would love to learn more, just be able to schedule a consultation, maybe even approach you as far as getting screens for their entire department. Where are the best places online to do that?
Well, number one, they could go to the Prenuvo website. There's like a direct platform there where they can see what the availability is at whatever clinic they are. And we have I forget the number now, how many clinics, 25 or so clinics across the US in basically in the major cities in different states. And they can directly book an opening. They can see the calendar or they can call in and have someone on our team going to assist them to book an appointment. That's at the one, single person level. But if their department has already somewhat of a program where they're referring out or even helping fund some of these exams for their members, they might want to reach out and see if that exists. And then there's often like a special pathway that's already pre-established for those kind of partner departments already. And if their department is interested in that but hasn't yet established that might be also a conversation they could bring up and reach out to our teams and see if a pathway could be established for that. In the meantime, anyone is able on their own to go to the website and book an appointment or call in to our team. And I don't have the number offhand, but we can get that for you after the call.
Brilliant. And then 25 at the moment, what is your goal to be in all 50 states?
I think so. It's not really the area that I'm actively involved in the kind of like company planning. But yeah, no, I think the goal is to make proactive care informed by radiology or whole body MRI at its foundational level accessible to everybody, both in terms of location and also in terms of cost as well. So we're always trying to make it faster, make it less expensive, and make it more widely available. So probably if it can be in every state, that'd be the ideal. In every major city, the ideal to work towards. Right now we're at 25. I don't know what the timeline is to get towards the ideal state, but that is sort of the goal we're working towards. If you look back over the last few years, when I started, as I mentioned, at Prenuvo about 5 years ago, we had one clinic, and then we accelerated to now 25 clinics. Most of them opened in the last, I think 1 to 2 years. So pretty good stage of growth right now, and hopefully soon will be more accessible to mostly everybody.
Brilliant. Well, I want to thank you so much. It's been such an amazing conversation. I'm genuinely, people know now if they've listened to this podcast for 9 years, I will not stand behind anything I don't believe in. The sponsors that come on the show are all products that I've used in the past, for example. But I was genuinely so impressed, not just by the actual imaging itself, but the medical history before, the consultation after. And as someone who's been in the wellness space, I'm no expert by any means, but I got a pretty good barometer on what I think is going to be important for this profession. And this is hands down one of them. So before I let you go, if people want to reach out to you and learn more about you, are there any other places online to do that?
Oh, yeah. I have a LinkedIn page, which, it's my name right here, Sefi Chodakiewitz. I have my Prenuvo email. I'm not always the best at responding to direct emails to me, but if they want, anybody wants to learn more about our firefighter program or talk to me as one of the radiologists and get more information, it's Yosef, Yosef, at Prenuvo.com. And at least maybe I can point them in the right direction if I can't answer the question directly. And otherwise, just call anyone in the company if they want to. There's a special interest to reach out to me directly about research projects, collaborations, radiology. This idea of primary care radiology, they can call the company or email me directly, and happy to be connected with them.
Beautiful. Well, again, I want to thank you so much for being not only so generous with your time, but also just educating us on a bunch of areas that is very, very new technology, and coming on the Behind the Shield podcast. So thank you so much.
Thanks for having me.